What if your next toothache meant pure agony, with no end in sight? What if a trip to the dentist was a public spectacle of blood and screaming, for a tooth that still wasn't fixed, only removed? Step back into the harsh world of dental care for the medieval aged, during the long stretch of the Middle Ages, roughly from the 5th to the 15th century. Number 1. Halitosis and gaps, social suffering. Beyond the excruciating physical pain and the brutal procedures, medieval dental realities carried significant social consequences. Oral hygiene was largely non-existent for the common person, leading to chronic bad breath and rampant tooth decay. This had a profound impact on social interactions, personal appearance, and even one's standing within the community. Attempting to carry on a conversation with someone whose breath was consistently foul was a daily reality. Halitosis, or chronic bad breath, was an unavoidable reality for most people in the Middle Ages. Without toothbrushes, toothpaste, or regular dental cleanings, plaque and food particles accumulated on teeth and tongues. The bacterial breakdown of these residues, combined with widespread gum disease and infected teeth, produced a constant unpleasant odor. This wasn't just a minor social faux pas, it was an ingrained part of daily life. Close-quarter conversations and intimate moments shared with family or friends would be pervaded by the scent of decay and infection. Kissing, a gesture of affection, would be a much different experience. People might try to chew on aromatic herbs like mint, parsley, or sage to mask the smell, but these were temporary solutions at best, doing nothing to address the underlying bacterial cause. The pervasive bad breath created an invisible barrier, subtly impacting all forms of human interaction. The lingering stench of unclean mouths, a mix of old food, decaying tissue, and active bacterial colonies would be a constant presence in any crowded space, from a bustling marketplace to a close-knit family home. It would cling to clothing and permeate the air, a silent but potent reminder of the widespread dental neglect. The concept of fresh breath was simply not a daily aspiration for most, but rather an occasional temporary relief achieved through crude methods. The loss of teeth also had a dramatic effect on appearance. As teeth decayed, broke, or were extracted, gaps would appear in the mouth. For many, these gaps were prominent, particularly in the front of the mouth. A smile that today is considered a sign of friendliness and confidence would have been a grimace revealing missing, discolored, or worn-down teeth. This disfigurement was not just aesthetic. It affected how a person was perceived in their community. A young person with missing front teeth might face social stigma, potentially impacting their marriage prospects or their ability to secure certain types of employment where appearance mattered, such as courtier, merchant, or even a public speaker. While commoners were less concerned with aesthetics than nobility, even in rural settings, a healthy set of teeth implied youth, vitality, and health, traits that were highly valued. A toothless grin was a sign of age and hardship, marking an individual as someone who had endured much. For a woman particularly, missing teeth could significantly reduce her perceived beauty and, by extension, her societal value, in a period where physical appearance played a substantial role in marital alliances. A gap-toothed smile, while perhaps familiar, still carried a subtle weight of misfortune or neglect. Speech was also impacted by missing teeth. The tongue and lips rely on the teeth to form certain sounds correctly. Gaps, especially in the front of the mouth, could lead to lisps, whistling sounds, or difficulty articulating words clearly. For someone relying on their voice for their livelihood, such as a storyteller, a priest, or a merchant, haggling in the marketplace, this could be a significant hindrance. Even in daily conversation, constant effort might be required to be understood, leading to frustration and self-consciousness. The clear, crisp enunciation we often take for granted would have been a luxury for many. Sounds like surf, and third, would become distorted, often resulting in air escaping through the gaps, creating an embarrassing whistling or spitting sound. This constant impediment to clear communication would undoubtedly wear down a person's confidence and willingness to engage in prolonged conversations. The frustration of being misunderstood or the self-awareness of one's own speech impediment would add another layer of quiet suffering to their daily lives. The overall appearance of the medieval mouth was often one of decay and disrepair. Teeth were frequently stained, discolored by diet, lack of hygiene, and the effects of infection. They might be chipped, cracked, or worn down to the gums from abrasive foods. The gums themselves were often swollen, red, and bleeding, a clear sign of rampant periodontal disease. This was simply the accepted norm, the reality of living in an age without modern dental care. For those few individuals who managed to retain a full set of healthy teeth into adulthood, they would have been a rarity, perhaps even viewed with a degree of envy or curiosity. Their relatively pristine smiles would stand out in stark contrast to the general population. The very act of smiling for many would have been a reluctant one, revealing a landscape of dental deterioration. Beyond the social consequences, the constant discomfort and pain associated with poor dental health also had a psychological toll. Living with chronic toothaches, sore gums, and the inability to eat comfortably could lead to irritability, depression, and a general decline in quality of life. The fear of another toothache, or the dread of an impending extraction, would hang over many individuals, influencing their daily decisions and their overall outlook on life. The lack of control over their own oral health, the knowledge that any relief would be temporary or brutally obtained, fostered a sense of helplessness. The pervasive background noise of pain, both physical and emotional, would erode a person's spirit, dimming their enthusiasm for life and interaction. Their participation in community events, their joy in simple pleasures, could be dampened by the ever-present ache or the self-consciousness about their appearance. For the wealthy, while they could afford some of the rare, rudimentary prosthetics, or access the services of more learned physicians, their dental issues were often exacerbated by their diet, which increasingly included refined sugars in the later medieval period. While they might have managed to mask their missing teeth with crude dentures for special occasions, the underlying problems of pain and infection were still very real. Their attempts at cosmetic fixes were often more painful than the gaps themselves, leading to irritation, sores, and sometimes further infection. The social suffering, therefore, was not limited to the lower classes, though it manifested differently. A noble might hide their dental woes behind a veneer of etiquette, but the private torment would be no less profound. The social suffering extended to public perception of health. A healthy set of teeth was not just about appearance. It was a visible indicator of overall well-being. Someone with a mouth full of decaying teeth and inflamed gums would be seen as unhealthy, perhaps even sickly. In a time when disease was poorly understood and often attributed to divine displeasure or moral failings, a visibly decaying mouth could subtly contribute to negative perceptions of an individual's character or status. An individual whose teeth were clearly rotting away might be viewed as less robust, less capable, or even less favored by divine powers. This visual signal of poor health could in turn affect opportunities for marriage, employment, or even acceptance within certain social circles. The condition of one's mouth was a public record of one's health, and by extension one's fortune. In the end, the medieval mouth was not just a place of physical agony and crude interventions, it was also a source of constant social suffering. The pervasive bad breath, the visible gaps from missing teeth, the difficulty with speech, and the overall disfigurement of a decaying mouth were daily realities that shaped how individuals interacted with their world. These aspects of dental health, often overlooked in historical accounts of pain, painted a grim picture of the social and psychological challenges faced by the medieval aged, adding another layer to the harsh realities of their dental care. Number 2. Extraction as the only exit strategy. In the grim landscape of medieval dental care, the concept of restorative dentistry, of saving a tooth, was virtually non-existent. There were no fillings to repair cavities, no root canals to clear infections within the tooth, and no crowns to protect weakened teeth. For almost every significant dental problem, the only available cure was extraction. This brutal reality meant that a person suffering from a toothache, no matter the underlying cause, would eventually face the prospect of having the offending tooth violently ripped from their jaw. This was not a last resort. It was often the first and only real solution offered. The notion of a tooth having inherent value beyond its immediate function was largely absent from the common medical mindset. If a tooth had a cavity, no matter how small, it was a ticking time bomb. Without the ability to clean out the decay and fill the hole, the cavity would inevitably grow deeper, reaching the sensitive pulp chamber and eventually leading to infection. Once infected, the tooth became a constant source of pain and potential systemic illness. The medieval solution was to remove the tooth. The idea was to eliminate the source of pain and infection by simply removing the entire structure. This meant that perfectly good parts of the tooth were sacrificed along with the diseased parts, simply because the technology and knowledge to preserve them did not exist. The choice was not about repair, but about removal. A small, treatable cavity in modern times would be a direct path to a painful extraction in the medieval world, an unfortunate and unavoidable progression. The consequence of extraction was not just the momentary agony of the procedure itself. It was the permanent void left in the mouth. Missing teeth made eating incredibly difficult, especially hard or chewy foods. People would have to adapt, often chewing predominantly on one side of their mouth or resorting to softer, more easily digestible foods. This limitation affected nutrition and overall health as varied and robust diets became challenging. A peasant already struggling for adequate food would find it even harder to gain sustenance with a compromised ability to chew. Their digestive system would work harder, their nutrient absorption potentially suffering, leading to overall weakness and susceptibility to other illnesses. The act of eating, a fundamental human need and pleasure, was transformed into a laborious and often uncomfortable task. Speech could also be impacted, especially with missing front teeth, leading to lisps or difficulty forming certain sounds, which could affect social interactions and even employability. The way words were formed relied heavily on the physical presence of teeth, and their absence created audible changes that were difficult to overcome. Furthermore, when a tooth is extracted, the bone that once supported it begins to resorb or shrink. In the medieval mouth, this bone loss would accelerate over time, causing changes in facial structure, making the jaw appear sunken and the chin more prominent. For individuals who had multiple teeth extracted, especially in the front of the mouth, this could lead to significant disfigurement, affecting their appearance and confidence. This was a particular concern for women whose appearance played a role in social standing and marriage prospects. The cheeks could appear hollow, and the lips might sink inwards, prematurely aging a person's face. The lack of preventative care meant that the cycle of decay and extraction was often continuous. A person might have one tooth extracted only for another to develop a cavity or become infected a few months or years later. Over a lifetime, many individuals would lose numerous teeth, leaving them with sparse, gappy mouths, or in old age completely edentureless, toothless. The absence of teeth led to further dietary restrictions and discomfort, a harsh reality for the elderly in a period where life expectancy was already low. Imagine the cumulative effect of a lifetime of extractions, each leaving its painful legacy eventually transforming a mouth into a landscape of gaps and exposed gums. Each lost tooth made chewing more difficult, placing greater strain on the remaining teeth, accelerating their wear and eventually their own loss. It was a vicious cycle of deterioration. Attempts at dental prosthetics were extremely rare and largely unsuccessful. Some historical accounts mention rudimentary dentures made from animal teeth, carved bone, or even human teeth acquired from cadavers or battlefield casualties. However, these were crude, ill-fitting, and impractical. They were not designed for function, but rather for aesthetic purposes, for the very wealthy, who might commission such a device to fill a visible gap. They would often be held in place with wires, or simply rest loosely in the mouth, offering no real chewing ability and likely causing irritation and further infection. The materials used, like ivory or bone, were porous and difficult to clean, making them breeding grounds for bacteria. The vast majority of medieval people lived with their missing teeth, adapting as best they could. The concept of implants or custom-fitted crowns was pure fantasy, belonging to a distant, unimaginable future. The idea of preserving a tooth, cleaning it, or treating the internal infection of the pulp was beyond the scope of medieval medical knowledge. The complex anatomy of the tooth, its nerve and blood supply, was not understood. The thought of performing a root canal, which involves meticulously cleaning out the infected pulp from within the root canals and filling them, would have been incomprehensible. The very concept of germs causing infection was centuries away from discovery. Therefore, the only logical step for a barber surgeon when faced with a painful infected tooth was to remove it entirely, eliminating the perceived source of the problem. Their actions, though brutal, were a direct consequence of their limited understanding and tools. This emphasis on extraction as the primary solution highlights the reactive, rather than proactive, nature of medieval dental care. There was no concept of regular dental checkups, no advice on brushing or flossing, no fluoride treatments to strengthen enamel. Dental care was sought only when pain became unbearable, and by that point, the tooth was usually beyond any form of preservation. The extraction was seen as a necessary evil, a painful rite of passage to escape an even greater torment. It was a testament to the limitations of medical science, the prevalence of suffering, and the resigned acceptance of tooth loss as an inevitable part of life in the medieval world. The exit strategy was not to save, but to destroy, leaving a lasting impact on the lives and faces of those who endured it. Number 3. A diet designed for D. The medieval diet, while often presented as simple and natural, harbored several characteristics that contributed significantly to widespread dental problems. For the majority of the population, particularly the peasants and common folk, the staple food was grain, predominantly wheat, rye, or barley. This grain was often ground in rudimentary mills, often using stone grinders. The grinding process was imperfect, meaning that tiny fragments of stone from the millstones often ended up mixed in with the flour. When this flour was baked into bread, which formed the bulk of most meals, these abrasive stone particles were ingested. Every bite of bread, a daily ritual, contributed to the wear and tear on teeth. This constant friction, known as attrition, slowly but surely wore down the enamel, exposing the softer, more sensitive dentin beneath. Once the dentin was exposed, teeth became more susceptible to decay and sensitivity. This wasn't just a minor issue. Archaeological studies of medieval skeletal remains frequently show teeth worn down to the gums, sometimes with exposed pulp chambers, evidence of a lifetime of consuming stone-laden bread. The constant grinding against these tiny grit particles acted like a perpetual sandpaper, steadily eroding the protective outer layer of the teeth. Beyond the abrasive nature of bread, the overall diet was often carbohydrate-heavy. While the concept of sugar causing cavities was unknown, the reality of its effects was present. Honey was the primary sweetener available in Europe for much of the Middle Ages, and while not as refined or concentrated as modern sugar, it was still a source of fermentable carbohydrates. Honey was used to sweeten drinks, porridge, and certain dishes, providing a sticky, sugary residue that adhered to teeth. Sugarcane began to be introduced to Europe on a larger scale after the Crusades, particularly in the later medieval period. Initially, it was an incredibly expensive luxury, accessible only to the very wealthiest nobles and merchants. For those who could afford it, regular consumption of refined sugar, in the form of sweet confections or sweetened drinks, rapidly accelerated tooth decay. While limited to a small segment of the population, this elite group would have experienced a different, perhaps even more rapid onset of severe cavities. Their newly acquired sweet tooth became a direct cause of their dental woes, an ironic consequence of their prosperity. The diet lacked many of the preventative measures we now associate with good oral health. Fresh fruits and vegetables, while available seasonally, were not consumed in the quantities recommended today. For much of the year, especially in winter, the diet consisted largely of preserved foods, grains, and salted meats. The fibrous nature of many raw fruits and vegetables, which can help clean teeth naturally by scraping away plaque, was largely absent from the everyday meal. The hard, crunchy texture of apples or carrots, for example, which act as natural toothbrushes, was rarely a consistent part of the medieval diet. Furthermore, acidic foods which can erode enamel were common, such as fermented drinks like ale and wine, and acidic fruits or vinegars used in cooking. The constant bathing of teeth in acidic environments, coupled with lack of brushing, accelerated enamel erosion. The concept of oral hygiene was rudimentary, almost non-existent for the general populace. There were no toothbrushes as we know them, nor toothpaste. People might use chewing sticks, essentially twigs with frayed ends, or rough cloths to rub their teeth. Herbs like mint or sage might be chewed for freshening breath, but these offered little protection against the cumulative effects of diet. Water, often contaminated, was not used for rinsing the mouth as a regular practice, and even if it was, it would not effectively remove plaque or food particles. The constant presence of food debris and plaque on teeth created an ideal environment for bacteria to thrive. These bacteria fermented the carbohydrates, producing acids that dissolved tooth enamel, leading to the formation of cavities. The bacterial colonies, undisturbed, formed tenacious films on the teeth, relentlessly breaking down the tooth structure day and night. The lack of varied and nutrient-rich foods also impacted overall dental health. Deficiencies in vitamins and minerals, particularly Vitont, Netscurvy, and Vicnati, rickets, could weaken bones and gums, making teeth more susceptible to disease and loosening. For instance, chronic scurvy would cause gums to bleed, swell, and become incredibly painful, leading to tooth loss. While severe scurvy was less common among common people with access to some vegetables, it was not unheard of, especially during long sieges or famine. Weakened gums provided an easier pathway for bacteria to invade the underlying bone, further compromising tooth stability. The practice of grinding teeth, bruxism, often a result of stress or malocclusion, also contributed to dental wear. The coarser nature of the medieval diet required more vigorous chewing, which could exacerbate existing tooth problems. The daily grind of eating rough, unrefined foods meant constant stress on the teeth, leading to cracks, chips, and further abrasion. Every meal contributed to the slow destruction of dental structures. Beyond diet, other factors contributed to poor dental health. Smoking, while not tobacco, was practiced by some using other substances which could stain and damage teeth. The use of teeth as tools, for example, by craftsmen or weavers who might hold threads or materials in their mouths, also contributed to specific patterns of tooth wear and damage. Certain occupations, such as leatherworking, involved biting and pulling materials, leading to distinct dental wear patterns for those individuals. The teeth were often seen as functional tools, used not just for eating but for a variety of tasks that put them under immense strain. The result of this combination of abrasive foods, high carbohydrate intake, limited hygiene, and nutritional deficiencies was a population plagued by widespread dental problems. Cavities were rampant, often progressing to painful abscesses. Periodontal disease, with its inflamed bleeding gums and loose teeth, was common. Teeth were often worn down to stumps, discolored, or broken. The pain associated with these conditions was a constant presence for many. The medieval diet, though it sustained populations, inadvertently contributed to a silent epidemic of dental suffering, making every meal a potential contributor to future agony and every bite a step closer to tooth loss. It was a cruel irony that the very sustenance of life was also a slow poison for their teeth. Number 4. The terrifying tucket. The instruments used for dental care in the medieval period were a far cry from the sleek, sterilized, precision tools of a modern dentist. These were crude, often brutal devices, designed for brute force rather than finesse. Their appearance alone would have been enough to strike terror into the heart of anyone suffering from a toothache, a silent promise of the agony to come. Made primarily of iron, bronze, or steel, they were heavy, unrefined, and often stained with rust or the remnants of previous extractions. The metallic glint or dull sheen of aged iron would offer no comfort, only a stark preview of the pain to be endured. The most common extraction tools were various forms of forceps and tooth keys. Forceps, in their medieval iteration, bore little resemblance to the delicate, finely tuned instruments used today. They were large, robust pincers, often resembling blacksmith's tongs, designed to grip the entire tooth. The ends were not shaped to conform to the contours of a tooth, but were rather blunt and broad, capable of crushing the tooth if misapplied, or tearing the gums. Some might have slight curves or points, but precision was not their strong suit. These heavy iron tools were unwieldy, often requiring considerable force to maneuver within the narrow confines of the mouth. The grip was often poor, leading to slips that could damage adjacent teeth, the tongue, or the delicate soft tissues of the mouth. The sound of these metal tools clanking together or being roughly placed in the mouth would have sent shivers down the spine of any patient, signaling the start of a barbaric procedure. The very weight of the metal in the barber surgeon's hand conveyed a sense of unyielding power, meant to overcome the resistance of a firmly rooted tooth. For the removal of molars, particularly difficult to reach and with multiple roots, the tooth key was the instrument of choice. As mentioned earlier, this device looked disturbingly like a large antique door key, with a claw at one end. The claw would be hooked over the crown of the tooth, while a bolster or fulcrum at the base of the claw would be placed against the gum or jawbone. The barber surgeon would then grasp the handle and rotate the key, essentially twisting the tooth out of its socket. This method was incredibly traumatic. The rotational force often fractured the tooth, leaving root fragments embedded in the bone. It frequently dislocated the jaw, fractured the jawbone itself, or tore large sections of the gum and surrounding tissues. The sheer leverage applied by the key meant that collateral damage was almost guaranteed. The patient would feel not just the tooth being pulled, but the surrounding bone and gum being ripped and crushed. The metal on bone contact, the grinding and snapping sounds would be a horrifying symphony of destruction, a cacophony of pain echoing through the small, crowded barbershop. The handle, often made of rough wood or bone, would be gripped with grim determination, giving the barber surgeon maximum leverage to overpower the tooth. Other tools included various levers and elevators. These were essentially sharp-tipped metal rods or blades used to pry teeth out of their sockets, particularly if a tooth was broken at the gum line or if root fragments needed to be removed. These tools could easily slip, piercing the gum, tongue, or cheek, causing deep lacerations and increasing the risk of infection. They were also used to separate the tooth from its periodontal ligament, a painful process even with modern local anesthesia. The barber surgeon's grip on these levers would have been firm, perhaps even brutal, as they wrestled with a deeply embedded tooth. The patient's head would need to be held still, often by an assistant or a strong family member, as the practitioner exerted immense force. The scraping sound of metal against bone as the lever pried at the tooth would be chilling, a sound of destruction rather than healing. Beyond extraction, other dental procedures were rare and equally crude. There were no drills as we know them. Any attempt to access a decayed area would involve scraping with a sharp object or perhaps attempting to burn the decay away with a heated wire, an excruciating and largely ineffective method. The agonizing heat would cause immense pain, and the burning tissue would create a noxious smell, yet fail to truly eliminate the deep decay. Attempts at cleaning teeth were rudimentary, often involving scraping with a metal instrument or rubbing with a coarse cloth and abrasive powders. The aim was not to prevent decay, but perhaps to remove visible tartar or to whiten teeth for aesthetic purposes, often at the cost of damaging the enamel. These scraping tools, often blunt and harsh, would not only remove tartar but also scratch the tooth surface, creating new pathways for bacteria to thrive. The condition of these tools added another layer of horror. They were often unkempt, rusty, and coated with dried blood and tissue from previous patients. Sterilization was an unknown concept. After an extraction, a tool might be wiped on a dirty cloth or simply rinsed with water before being used on the next patient. This meant that each instrument was a vector for disease transmission. Blood-borne pathogens, though unknown at the time, were easily spread from one person to another. Infections like tetanus, syphilis, and other bacterial or viral diseases could be unwittingly transferred from one patient to the next, turning a painful but potentially survivable extraction into a death sentence. The mere thought of a rusty, blood-stained metal instrument being plunged into one's mouth is enough to make anyone shudder. The sight of dried blood caked onto the hinges or claws of the instruments would be a stark visual warning of the unsanitary conditions. The lack of precision in these tools meant that damage to surrounding healthy tissues was almost inevitable. It was not uncommon for adjacent teeth to be fractured or loosened during an extraction. The gums would be torn, creating large open wounds susceptible to infection. The tongue and cheeks, often inadvertently caught in the struggle, could be severely bitten or lacerated. The jawbone itself was at risk of fracture, especially with the use of the tooth key. Such fractures were incredibly painful and difficult to heal in the medieval era, leading to prolonged suffering, disfigurement, and sometimes fatal infections. A fractured jaw meant unimaginable pain with every movement, every attempt to eat, for weeks or even months. The tools of the medieval barber-surgeon were not designed for comfort or preservation. They were instruments of forceful removal, a testament to the brutal realities of the age. Their very existence speaks volumes about the limitations of medical knowledge and the extreme measures people were willing to endure to escape unbearable pain. The terrifying tourniquet was a symbol of desperation, a collection of crude implements that inflicted more pain and injury than they alleviated, leaving a legacy of suffering and disfigurement in their wake. For anyone needing dental care in the medieval period, the sight of these tools was a stark reminder of the painful ordeal that awaited them, a prelude to a battle between a suffering human and a crude, unforgiving piece of metal. Number 5. When your cure was a rabbit's brain. In an era devoid of scientific understanding of disease, and with limited effective medical interventions, people often turned to supernatural beliefs, folk remedies, and superstitious practices to alleviate dental pain. These cures ranged from the bizarre and disgusting to the potentially harmful, reflecting a desperate search for relief in a world that offered very little. The prevailing belief was that toothaches were caused by toothworms, tiny, invisible creatures that burrowed into the teeth, gnawing away at them and causing immense pain. This belief was widespread across many cultures and persisted for centuries, influencing nearly every attempt at dental self-treatment. This meant that many cures were aimed at expelling or killing these mythical worms rather than addressing the actual causes of decay or infection. One truly unsettling remedy involved the use of a rabbit's brain. Medieval texts describe a concoction made from a rabbit's brain, sometimes mixed with other ingredients like salt or herbs, which would then be applied directly to the aching tooth or gum. The rationale behind such a practice is murky perhaps, stemming from a belief in sympathetic magic, where properties of an animal were transferred to the afflicted person. There was, of course, no actual efficacy in this. The brain matter would do nothing to alleviate pain or cure infection, and in fact applying raw animal tissue to an open wound or infected area could introduce new pathogens, making the situation worse. The putrid smell alone would have been repulsive, let alone the thought of such a mixture in one's mouth. The warm, mushy consistency would be deeply unpleasant against inflamed gums. Such a remedy speaks to the profound desperation of those seeking any form of relief, no matter how unappetizing or illogical. Another common and equally ineffective approach involved burning specific substances and inhaling the smoke. Believing it would drive out the toothworm's henbane seeds were a popular choice for this. People would place henbane seeds on hot coals or a hot plate and inhale the smoke, sometimes holding a funnel over their mouth to direct the fumes directly towards the painful tooth. Henbane is a plant with psychoactive properties, and inhaling its smoke could certainly produce a dizzying or slightly narcotic effect, perhaps offering the momentary distraction from the pain. However, it also contains toxic alkaloids, and inhaling its smoke could cause dizziness, hallucinations, dry mouth, blurred vision, and in higher doses even convulsions or coma. Some accounts suggest that people would hold a bowl of water below their mouth to catch the worms that supposedly fell out in the smoke, often seeing small black specks, which were likely nothing more than charred henbane seeds or bits of debris, mistaken for expelled parasites. The choking sensation, the acrid smoke, and the potential for severe poisoning were all part of this terrifying ritual. Beyond these more extreme examples, many folk remedies focused on topical applications. Garlic, known for its strong odor and perceived medicinal properties, was often pounded into a paste and applied directly to the aching tooth or rubbed on the gum. While garlic does possess some anti-miting properties, its efficacy against deep-seated dental infections or cavities was minimal. The strong burning sensation it produced might have temporarily distracted from the underlying pain, but it did not address the root cause. Other common applications included herbs like rosemary, sage, or parsley, which might have offered some mild antiseptic or soothing properties, but again were largely ineffective against advanced decay or infection. Ground pepper, salt, or even vinegar were also applied, often causing more irritation than relief, a burning sensation on already inflamed tissue. Superstition played a huge role in determining when and how to seek treatment. Astrology was deeply intertwined with medieval medicine. The position of the moon, the stars, and the planets was believed to influence bodily humors and the outcome of medical procedures. An extraction might be advised only when the moon was in a certain phase or when specific astrological signs were ascendant, supposedly to ensure a more favorable outcome or to reduce bleeding. For a person suffering excruciating pain, having to wait for the correct astrological alignment could mean prolonged agony, sometimes for days or even weeks. This belief in celestial influence meant that practicality often took a backseat to mystical considerations. The constant consultation of star charts and lunar calendars dictated when a person could even attempt to find relief. Religious rituals and prayers were also a primary source of comfort and healing for many. People would pray to saints known for healing powers, such as Saint Apollonia, the patron saint of dentistry, who suffered martyrdom by having her teeth pulled out. Relics of saints, supposedly possessing miraculous healing properties, might be touched to the afflicted tooth or kept near the sufferer. Pilgrimages to holy sites, often lasting weeks or months, were undertaken in the hope of divine intervention. While these practices offered psychological comfort and hope, they provided no physical relief or cure for the underlying dental pathology. The pain would often continue unabated, forcing the faithful to endure their suffering as a test of their devotion. The Church offered solace and a sense of meaning to the suffering, but no actual cure. Some more curious practices involved attempts to transfer the pain. It was believed that touching an aching tooth to a specific type of tree or plant could transfer the ailment. For example, some traditions suggested touching the tooth to a willow tree or a hazelnut tree. Others believed that spitting 3 times into a frog's mouth or holding a frog to the cheek could absorb the pain. These practices were rooted in ancient animistic beliefs and sympathetic magic, where ailments could be transferred from one living thing to another, or from a person to an inanimate object. There was no scientific basis for any of this, of course, but for people facing unrelenting agony, any glimmer of hope, however irrational, was seized upon. The cold, slimy skin of a frog against a throbbing cheek might offer a temporary superficial coolness, but nothing more. Another widespread practice involved applying a mixture of various ingredients to the aching tooth or gum, often including urine, feces, or other bodily fluids. These unsanitary concoctions were believed to possess medicinal properties or to draw out the evil causing the pain. For instance, some recipes involved applying a poultice of human urine mixed with herbs. Not only were these remedies ineffective, but they significantly increased the risk of secondary bacterial infections, introducing dangerous pathogen directly into an already compromised oral cavity. The putrid smell and disgusting texture of such applications would add another layer of misery to the patient's already dire situation. The sheer lack of understanding of hygiene and infection pathways made these attempts at self-medication incredibly dangerous, often turning a local infection into a systemic one. The sheer variety and strangeness of these medieval cures highlight the desperation of people suffering from dental pain in an age without modern medicine. From burning strange seeds and inhaling noxious fumes to applying animal brains or human waste, the measures taken to alleviate agony were often rooted in superstition rather than any true understanding of anatomy or disease. These practices were not just ineffective, they often carried their own risks, potentially worsening the condition or introducing new life-threatening infections. The medieval, aged, grappling with toothaches, were truly in a world where hope was often found in the bizarre, and suffering was an unavoidable part of life. Number 6. The barber surgeon's brutal office. When the pain became unbearable, and folk remedies offered no respite, the medieval person had limited choices for professional intervention. The most accessible, and often the only, option was the barber surgeon. These individuals were not medical doctors in the modern sense. They were craftsmen whose primary trade was haircutting and shaving. However, their sharp razors and familiarity with blood made them the go-to practitioners for a range of minor surgical procedures, including most prominently tooth extraction. Their office was typically a corner of their barber shop, often a public space where onlookers could gather, drawn by curiosity or morbid fascination. This was not a private, sterile environment. It was a bustling, often chaotic setting, filled with the everyday sounds and smells of a working shop. The barber surgeon's training was not academic. It was an apprenticeship, learning by doing, often under the tutelage of an elder barber surgeon. They absorbed practical skills through observation and repetition, rather than formal study of anatomy, physiology, or hygiene. Their understanding of the human body was rudimentary at best, often based on ancient Greek and Roman theories of humors, which posited that illness was caused by an imbalance of four bodily fluids: blood, phlegm, black bile, and yellow bile. This meant that tooth pain was often attributed to a hot humor or a cold humor in the tooth, rather than a bacterial infection or decay. Such a misunderstanding of the root cause of the problem directly impacted the effectiveness of their cures, leading to misguided attempts at balancing humors rather than treating the actual disease. The unsanitary conditions of the barber surgeon's establishment are difficult to overstate. Cleanliness as a concept, especially regarding germ theory, was centuries away from discovery. Tools were rarely, if ever, sterilized. The same instruments used to cut hair or shave a beard might be used moments later to pry out a tooth. The instruments themselves were often simply wiped clean with a cloth, perhaps rinsed with water, but never subjected to heat or chemical disinfectants that would kill bacteria and viruses. Blood from a previous extraction might still be visible on the forceps or the tooth keys, dried and caked onto the metal. This meant that each extraction carried a significant risk of infection. A seemingly successful extraction could quickly turn into a deadly ordeal if bacteria from a contaminated tool entered the open wound in the jaw. This lack of hygiene contributed directly to complications like osteomyelitis, a severe infection of the bone, or even systemic sepsis, a life-threatening infection of the bloodstream that could spread throughout the entire body. The air itself, filled with dust and everyday grime, would add to the microbial burden. The public nature of these procedures was also a stark reality. There was no discreet waiting room, no privacy curtain. A patient would sit on a simple wooden stool or a chair, often in the midst of other customers, waiting for a shave or a haircut. The sounds of the extraction, the patient's cries of pain, the scraping of metal against bone, were all part of the daily soundscape of the barbershop. This lack of privacy added another layer of humiliation to an already agonizing experience. The patient had to endure not only the physical torment, but also the stares and whispers of onlookers. This public display served a dual purpose. It demonstrated the barber surgeon's skill and boldness, and it also served as a terrifying warning to anyone else suffering from a toothache, a gruesome spectacle that served as a grim reminder of life's harshness. Children would witness these scenes, shaping their own dread of tooth pain from a young age. The procedure itself was typically brutal. Without effective anesthesia, the patient was fully conscious, experiencing every searing moment of the extraction. The barber surgeon might offer a swig of strong ale or wine, or perhaps a small dose of opium tincture. But these offered only minimal dulling of the senses against the intense pain of a tooth being wrenched from its socket. The process began with the barber surgeon examining the offending tooth, often with rudimentary light from a window or a candle. There was no X-ray to determine the tooth's root structure or any underlying complications. The decision to extract was based purely on visual inspection, and the patient's complaints of severe pain or looseness. The barber surgeon might poke and prod with a dirty finger, further exacerbating the pain and spreading infection. Once the target tooth was identified, the barber surgeon would select an instrument. For front teeth, large, crude forceps were common, designed to grip the tooth. For molars, which were harder to reach and often had multiple roots, the tooth key was a popular and terrifying device. This instrument, shaped somewhat like a door key, had a claw at one end that would be placed over the top of the tooth, while a fulcrum at the base of the claw would be placed against the gum. The barber surgeon would then rotate the key, using leverage to literally wrench the tooth out of its socket. This often resulted in fractured teeth, damaged surrounding teeth, broken jawbones, or extensive soft tissue damage. The sound of a tooth cracking or bone splintering was a common accompaniment to these procedures, a visceral sound that would haunt the memory of the patient. The barber surgeon would brace themselves, placing a firm hand on the patient's head before applying immense, unyielding force. The process was rarely quick or clean. The tooth might break apart, leaving fragments of root embedded in the jawbone. This left a constant source of irritation and infection, often leading to chronic pain and drainage of pus. The sheer force required to extract a tooth could lead to heavy bleeding. Without modern understanding of clotting or sterile gauze, the bleeding could be profuse and alarming, filling the patient's mouth with blood and making it difficult to breathe. The barber surgeon might try to staunch the flow with a piece of cloth or by packing the empty socket with herbs, but often the patient was simply left to bleed until the body's natural clotting mechanisms took over. Assuming they did, the pool of blood on the floor or in the basin would be a common sight. After the extraction, there was little to no aftercare instructions given, beyond perhaps avoiding hard foods for a day or two. The wound was left open, a direct pathway for any lingering bacteria from the dirty instruments or the unhygienic environment to enter the bloodstream. Infection was a constant threat, and many people likely died days or weeks after a seemingly successful extraction from complications that today would be easily treatable with antibiotics. Sepsis, tetanus, and severe local infections were all potential outcomes, turning a moment of desperate relief into a slow, agonizing demise. The barber surgeon's lack of true medical knowledge extended beyond hygiene. They did not understand the intricate nerve pathways or the delicate structures of the jaw. They simply saw a painful tooth and believed extraction was the only answer, a crude but often necessary measure to alleviate unbearable suffering. They were not concerned with preserving teeth or with the long-term consequences of multiple extractions. A person who had many teeth extracted would be left with gaps, difficulty eating, and altered facial appearance, consequences that were simply accepted as part of life. The barber surgeon's role was to perform a swift, albeit brutal, act of removal, not to provide comprehensive dental care. Their practice was a testament to the desperate measures people took to escape the relentless pain of medieval dental disease, a stark reminder of the rudimentary state of medical knowledge and practice during this period. Number 7. The agony of the unmedicated mouth. The human body possesses a remarkable capacity for pain, and in the medieval era, that capacity was tested daily for those suffering from dental afflictions. Toothaches were not mere nuisances, they were profound, debilitating torments that could incapacitate even the strongest individual. When a tooth began to ache in a medieval mouth, it rarely stopped without extreme measures or the complete destruction of the nerve. The concept of pain relief, as we understand it today, a carefully calibrated dosage of medication to soothe the nerves, was utterly foreign. People simply endured. They endured a persistent, throbbing ache that resonated deep within their jawbone, a relentless pounding that made sleep impossible, and eating an act of excruciating courage. This was not a temporary discomfort. This was a constant companion, a dull, nagging throb that would suddenly flare into a sharp, searing stab, as if a hot poker had been thrust into the very core of their being. The suffering was personal, relentless, and all-consuming, trapping the individual in a cycle of ceaseless torment. The common cavity, a small breach in the enamel that allows the delicate pulp within the tooth to become exposed, was a prime culprit. Today, a quick drill, a filling, and the pain vanishes. In the Middle Ages, that tiny hole was a gateway to relentless suffering. Each sip of cold water, each bite of warm food, each breath of crisp air could send electric shocks of pain through the jaw. As the decay progressed, Bacteria invaded the pulp, leading to inflammation and infection. This infection did not just cause pain. It caused swelling, creating pressure within the rigid confines of the tooth. The pressure intensified the throbbing, turning the ache into a relentless drumbeat of agony. This internal pressure could force pus to form, creating an abscess, a pocket of infection that could spread through the jawbone, affecting adjacent teeth, the gums, and even the face itself. The face would swell, becoming distorted and discolored. The skin stretched tight over the inflamed tissues, often accompanied by a foul discharge from the gum. The lymph nodes in the neck might swell, becoming tender to the touch, indicating the body's desperate struggle against the encroaching infection. Fever often accompanied these severe infections, racking the body with chills and sweats, further weakening an already suffering individual, leaving them weak and exhausted. For someone living in a village, far from any practitioner of medicine, the only recourse against this escalating pain was desperate hope, and perhaps a few traditional remedies passed down through generations. These remedies were often ineffective against deep-seated infection. Some might try to apply hot compresses to the cheek, hoping the warmth would draw out the bad humors or reduce the swelling. Others might chew on certain herbs, believing in their mystical properties rather than any true analgesic effect. The pain, however, largely remained, a constant oppressive weight that overshadowed every waking moment. Productivity vanished. A farmer could not work his fields with an abscessed tooth. A weaver could not focus on her loom, her hands idle, her mind consumed by the pain. Children cried incessantly, their small bodies racked by agony. Adults simply withered under the strain, their faces drawn and pale, their eyes hollow from sleepless nights. The sheer exhaustion that accompanied prolonged, intense pain was reality for countless medieval individuals, reducing them to mere shells of their former selves. The sophisticated painkillers we rely on today, like ibuprofen or acetaminophen, were centuries away from discovery. Even stronger prescription phobies would not exist in their refined forms for many more centuries. The medieval world offered very limited options for systemic pain relief. Opium, derived from the poppy plant, was known and used. However, its preparation and dosage were far from precise. Opium was available in various forms: raw gum, dissolved in wine, or mixed into poultices. A person might chew on a piece of raw opium or drink a concoction containing it, hoping for a respite. The effects were often unpredictable. Too little and the pain continued its relentless assault. Too much, and the individual could become dangerously drowsy, nauseous, or even fall into a coma. The line between sedation and danger was a blurred one, often crossed unintentionally, leading to further complications or even death. Furthermore, opium was an expensive commodity, not readily available to the common peasant struggling with a toothache. It was more likely to be found in the possession of the wealthy or dispensed by a skilled physician, a rare commodity outside of major urban centers. Alcohol, particularly strong wine or ale, was another common anodyne. People would drink copious amounts, hoping to dull the pain and induce a state of oblivion. While alcohol certainly numbed the senses and could lead to temporary forgetfulness of the pain, it also dehydrated the body and impaired judgment, making a bad situation worse in the long run. The hangover that followed merely compounded the misery once the alcohol's temporary effects wore off, leaving the individual with both a splitting headache and a throbbing tooth. The numbing effect of alcohol was also short-lived, forcing continuous consumption, which in turn could lead to dependence and other health issues, creating a new set of problems on top of the original ailment. It was a trade-off, a desperate bargain made between temporary relief and long-term consequences. Mandrake root, another plant with narcotic properties, was also used, sometimes administered as a sleeping draught. Its use was steeped in superstition, partly due to the root's resemblance to a human figure and its hallucinogenic properties. Preparing mandrake was a dangerous endeavor, as its potency varied wildly. A skilled herbalist or physician might know how to prepare it in a somewhat controlled manner, but for the average person, it was a gamble. Too much mandrake could be fatal, causing respiratory depression and cardiac arrest. Its usage was often reserved for surgical procedures rather than daily toothache relief, because of its inherent dangers and the difficulty in dosing. The medieval person living with tooth pain faced a terrible choice: endure the agony or risk potentially fatal remedies in a desperate bid for relief. The suffering was not merely physical. The constant pain eroded mental. A person might pace their small dwelling at night, unable to find a comfortable position, tormented by the ceaseless throbbing. They might try to chew on specific herbs, press garlic against the aching gum, or even attempt to dig at the tooth themselves with a rusty nail, a desperate and dangerous act driven by the overwhelming need for relief, often resulting in self-inflicted wounds and further infection. The sheer desperation could lead to irrational behavior. The sounds of a medieval village at night would include not just the occasional cry of a child, but the quiet moans of adults unable to escape the torment within their own mouths. The constant pain would grind down a person's spirit, leaving them irritable, depressed, and unable to participate fully in family or community life. Their appetite would diminish, not just because of the pain of chewing, but because the constant agony made food unappealing. They would grow thin and weak, their immune system compromised, making them more susceptible to other illnesses and shortening their already precarious lives. Beyond simple cavities, other dental conditions brought their own unique forms of pain. A broken tooth, perhaps from chewing on a bone or a stray stone in bread, exposed the sensitive inner layers to the harsh environment of the mouth. The jagged edges could cut the tongue and cheek, creating additional wounds that could become infected, adding secondary pain to the primary agony. Periodontal disease. The inflammation and infection of the gums and bones supporting the teeth also caused widespread pain. Gums would swell, bleed easily, and become incredibly tender to the slightest touch. Teeth would loosen in their sockets, wobbling precariously with each bite, causing sharp, excruciating pain and making chewing an impossible task. The bones supporting the teeth would slowly erode, leading to even greater instability and eventually tooth loss. Each stage of these conditions represented a new escalation of suffering, with very few options for intervention. The reality was that for many, the pain continued its relentless march until the tooth or teeth simply disintegrated, fell out, or became so infected that the body's natural defenses finally succumbed. The infection, if left untreated, could spread beyond the mouth, traveling to the jawbone, into the sinus cavities, or in the most dire cases, to the brain, leading to a fatal systemic infection or brain abscess. Death from a toothache was a very real, though often unrecorded, possibility in the medieval world. A silent killer disguised as a mere discomfort. The agony of the unmedicated mouth was not just a historical footnote. It was a profound daily suffering that shaped the lives of countless medieval individuals, leaving an indelible mark of pain and desperation on their existence.